Hello and welcome to my channel. This lecture will be talking about the urinary bladder. So let's begin. The pelvic ureters. We studied the abdominal ureters. Once they cross the sacroiliac joint or the common iliac artery, which is anterior to the sacroiliac joint, so they are in the pelvis now, and they have the same length of the abdominal part. Descend on the lateral pelvic wall after crossing the common iliac artery. They lie on the fascia of the obturator internus, as you can see here, in front of the internal iliac artery, a vein, the lumbosacral trunk, and the sacroiliac joint. And then at the level of the ischial spines, as you see here, they turn anteromedially. There is a kink we talked about. This is a site for impaction of ureteric stones. They turn anteromedially and cross the cross medial to the obliterated umbilical artery, the obturator nerve and vessels, and the middle rectal artery, and then enter the base of the bladder, which is the upper part of the posterior surface of the bladder, the posterolateral angles of the urinary bladder. Now, once they enter the urinary bladder, they don't open right away in the cavity of the urinary bladder, but they have what's so-called the intramural part. They run for a while in the muscle layer, in the detrusor muscle of the urinary bladder, and losing their coats, the ureter, then end by opening in the upper angles of the trigone, as we will study later. In males, before it pierces the bladder or enters the bladder, it's crossed by the vas deferens or the ductus deferens here, as you can see here in the male. In the female, they are crossed by the uterine artery right above the lateral fornix of the vagina. So this is for the obstetricians to take care when they do vaginal hysterectomy, for example, and they want to ligate the uterine artery through the vagina. They take care not to ligate the ureter as well. Okay, so remember, this is very important. They are crossed in males by the vas deferens and in the females by the uterine artery above the lateral fornix of the vagina. Now, for the urinary bladder, it's simply a reservoir for urine and varies in shape and size and relations with distension. Mean capacity, of course, these are not exact numbers, but approximate numbers. Mean capacity between 120 and 320 in the average, in the most common sizes in human beings. Micturition starts at 280 milliliters. Now, if micturition at 280 milliliters, so awareness of urine before that. But up to 500 milliliters, half a liter, it's tolerated. After that, pain starts to develop, and it's carried by the T11 through L2 spinal cord segments and S2, 3, 4. That's through the pelvic splanchnic nerves. In the empty state, it has an apex, it has a base or a fundus, it has a superior surface, it has two infralateral surfaces, and a neck. Okay, you can see it inside. The neck is right opposite to the prostate in males. So remember, it has an apex, it has a base or fundus, which is the posterior surface. It has a neck, it has a superior surface, it has two infralateral surfaces. The apex points antero-superior above the upper border of the symphysis pubis, and it's connected to the urachus that goes to the umbilicus, raising the median umbilical fold, as we studied in the anterior abdominal wall from the inside. The base is posterior inferior. This is the base we're talking about, posterior inferior, triangular in shape. And in males, it's related to rectum, separated by the seminal vesicles. You can see the seminal vesicles here, the vas deferens here, and the rectovesical pouch we talked about in peritoneum. The upper part of the base of the bladder, upper part of the posterior surface of the bladder is covered by peritoneum. Remember, there is a slack, extra slack of peritoneum in males than females, because the uterus came between the urinary bladder and the rectum. So the superior surface is completely covered with peritoneum in males, and the upper part of the posterior surface. In females, it's related to the anterior vaginal wall. You can see here, this is the base of the bladder, posterior surface related to the anterior vaginal wall. This is the vagina, this is the posterior wall, and this is the anterior wall of the vagina. And the urethra is embedded in the anterior wall of the vagina. The neck of the urinary bladder, behind the symphysis pubis, of course. In males, it's related to the base of the prostate. Now, the base is the superior surface of the prostate. See, this is the base of the prostate, and the apex is downwards. So the neck is related to the base of the prostate, and in females, related to the fascia around the upper part of the urethra, and pierced by the internal urethral meatus, means that the urethra, of course this is in females, starts in the region of the neck of the bladder here in females, but it's not surrounded by a sphincter, as we will study later. And here it's related to the base or superior surface of the prostate, where it has a pre-prostatic part, the urethra, and then pierces the prostate. The superior surface has two superolateral angles. In males, peritoneum covers it all. See, the peritoneum is reflected from the junction of the middle and lower thirds of the rectum forward to cover the upper part of the posterior surface of the urinary bladder and all the superior surface of the urinary bladder. This is important difference between males and females. Okay, it's related, of course, the superior surface to sigmoid colon high above and coils of ileum. In females, the peritoneum does not cover the whole surface. It covers, leaves a part of it bare of peritoneum, the posterior part of the superior surface, and of course the base is not covered at all with peritoneum, because I told you the uterus now took much of the peritoneum that was between the rectum and the urinary bladder in males, in the case of males. It's reflected from the uterus, the peritoneum, at the level of the internal os. You can identify the internal os here. See these, grooved cavity of the cervix. Okay, they call it the palmate folds. The upper end of it is the internal os, and the lower end is the external os. See, the peritoneum is reflected opposite the level of the internal os of the uterus. The peritoneum laterally forms the paravesical fossae. See these fossae, these depressions, and the median umbilical fold. The infralateral surfaces anteriorly connected to the back of the pubis by the puboprostatic ligament in males and the pubovesical ligament in females. And posteriorly, the infralateral surfaces are related to the obturator internus and the levator ani, and of course they are not covered by peritoneum. So the only part covered by peritoneum is the superior surface in females, and the superior surface and upper part of posterior surface in males. Ligaments of the urinary bladder. We studied the pubovesical ligament, the puboprostatic ligament. These are true ligaments, but the urachus is considered a ligament because it fixes the bladder to the anterior abdominal wall. Not right away, because there's an area of connective tissue between the anterior part of the bladder and the abdominal wall, and the peritoneum is not adherent to the wall to give way for the bladder to distend. The sites of reflections of peritoneum at the sides of the bladder, as you can see here, are considered to be ligaments. The sacrogenital folds, reflections from the angles to the back, to the sacrum, they are called the sacrogenital folds. They are considered ligaments. The transverse folds you can see here at the superior surface are considered ligaments. All these reflections and peritoneum and true ligaments fix the bladder in position. So they are considered as ligaments of the urinary bladder. The peritoneum of urinary bladder, we studied the rectovesical pouch, the uterovesical pouch in females, the sacrogenital folds to the back, to the sacrum, and because at the anterior part of the bladder is not covered by peritoneum, the peritoneum reflected to the anterior abdominal wall. At the beginning of the reflection, it's not adherent to the wall. There is an area of connective tissue here, so that the bladder, when distends, it will raise the peritoneum with it. Means that in cystoscopy, suprapubic cystoscopies, in case of full bladder, only in case of full bladder, not an empty bladder, a full bladder will raise the peritoneum with it, so there will be an area suprapubic that is bare of peritoneum, so you can introduce the cannula of cystoscopy safely without being intraperitoneal. You will be extraperitoneal. But please remember, it's only in the case of full urinary bladder. Okay, the internal features of the urinary bladder. Of course, the mucosa, it's highly folded to allow for the distension of the urinary bladder. It's made of pseudo-stratified epithelium. I have a section of pseudo-stratified epithelium in the next slide. I will show it to you. It's not adherent to the muscle wall of the bladder. It's loose, but only fixed and smooth, adherent to the muscle wall, and smooth in the area of the trigone that you see here. See, this is the area of the trigone. It's the inferior part of the base of the bladder. This part does not distend. This part does not distend. Now the trigone, as you can see here, it's bounded by the internal urethral meatus, and superiorly by the ureteric openings, as you can see here. And because the ureters, as they go intramural in the muscle wall of the urinary bladder, they lose their outer coats, muscle coats, and they unite together to form an interureteric crest. Interureteric crest, which is pale in cystoscopy and used as a guide to guide you to the ureteric opening in cystoscopy. See that? At the floor of the urinary bladder, you'll see the uvulovesicae. This is a raised part of the floor of the bladder because of the push of the underlying middle lobe of the prostate, the uvulovesicae. With benign hypertrophy of the prostate, this uvula enlarges and obstructs the internal urethral meatus, especially when straining. Okay, especially when straining. Okay, This is a section of the mucosa of the urinary bladder, this transitional epithelium called transitional pseudostratified epithelium. Why pseudostratified? It looks like layers of cells, but actually it's only one layer of cells. See, only the nuclei are at different levels. The nuclei are at different levels, but they all have stick to the basement membrane of the pseudostratified epithelium. See that? Why? Because this one distended, the cell glide on each other, and this becomes thinner as the urinary bladder distends, and of course thickens again when the bladder empties. This section to show you the real, in a real specimen, trigone. This is the trigone, as you can see here. This is the uvula vesicae. See that? This is the uvula vesicae. These are the ureteric openings. This is the interureteric crest, and this is the internal urethral meatus. It's a beautiful specimen. This specimen to show you what you will see in cystoscopy, the area of the trigone. The muscular layer of the urinary bladder, it's called the detrusor muscle. All over the bladder, it's three layers: outer and inner longitudinal and middle circular layer. Only in that area of the trigone, it thins into two layers: the deep trigonal muscle, which belongs to the detrusor muscle, and the superficial trigonal muscle, actually derived from the walls of the ureters as they enter the urinary bladder. So only two muscle layers: inner deep trigonal muscle and superficial trigonal muscle. In males, the muscle thickens around the what's so-called the pre-prostatic urethra. Only this part. See parts of the urethra. This is the pre-prostatic, this is the prostatic, this is the membranous urethra, and this is the penile urethra. As you can see here, only thickens around the pre-prostatic urethra to form the internal urethral sphincter. It's not for the function of micturition. The main function of this sphincter is to close down the urethra high up, to prevent regurg of semen in the urethra to the inside of the urinary bladder. Got it? Again, the internal urethral sphincter is not for the micturition process, or else we will find an internal urethral meatus and internal urethral sphincter in females. But it's for the purpose that it closes the urethra when contracts high up during ejaculation to prevent the regurg of semen to the inside of the urinary bladder. This is the internal urethral sphincter. Of course, there is no internal urethral sphincter in females, but there is external urethral sphincter or urethral sphincter in both males and females. Here, it's called the deep perineal pouch. You will study this in the perineum. Here we have the external or the urethral sphincter in both males and females, and this acts in micturition. Okay, so actually this one is closed during ejaculation, this one is open during ejaculation. See the difference between the two sphincters? Okay. The blood supply of the urinary bladder, it takes from nearby arteries. There are two arteries named after the urinary bladder: the superior vesicle, the one you see here, from internal iliac, anterior division. The inferior vesicle supplies the posterior surface and the internal male sex organs, which is the seminal vesicle and vas deferens. This is a female, of course, but also in females the inferior vesicle supplies. It takes from uterine, takes from middle rectal, or inferior rectal, vaginal, from any artery nearby that shares in the supply of the urinary bladder. and the venous drainage. There is a plexus of veins on the infralateral surfaces of the urinary bladder connected to the prostatic venous plexus, also to the uterine venous plexus. All these plexuses are connected together and they drain into the internal iliac vein, the lymphatic with the vessels to the internal iliac lymph nodes. The nerve supply of the bladder, of course, it's autonomic, means visceral. It has sympathetic component and parasympathetic component. It gets its nerve supply from a vesical nerve plexus that's derived from the inferior hypogastric plexus and shared by the pelvic splanchnic nerves for the parasympathetic component. Now, the sympathetic supply is from T11 through L2, mainly to the posterior inferior aspect and neck in males. So here, in this part, in males, it's predominant sympathetic supply, but there is parasympathetic, but predominant sympathetic supply. Why? Ejaculation is sympathetic, so the sympathetic stimulation will contract the internal sex organs like the ampulla of the vas, like the seminal vesicle, like the prostate, and at the same time it will contract the pre-prostatic sphincter or internal urethral sphincter in the males to prevent regurg of the semen into the urinary bladder. Now, I told you about the uvula vesicae here. When there's a senile, we'll talk about this. Let's talk about this with the internal sex organs in the male. The parasympathetic component from S2 through 4, nervi urgentus, part of the pelvic splanchnic nerves. They stimulate the detrusor muscle, means contraction of the urinary bladder, evacuation of the urinary bladder, and inhibit the sphincter. Okay, and inhibit the sphincter, the internal, of course, the internal urethral sphincter in males, and inhibit the urethral sphincter also in males and females for the urine to pass all over through the urethra. Okay, this is about the sympathetic and the parasympathetic components. Now, awareness of micturition comes from full bladder. It runs in the spinal cord in the gracile tract, a dorsal column tract that's specialized for proprioception. From sensations carried through this gracile tract from the lower half of the body, lower limbs, and the pelvis, and it carries the awareness from the urinary bladder. But the pain sensation in the spinothalamic tract, it's the anterolateral system, anterolateral. The gracile tract is posterior column system. This is the anterolateral column system in the spinal cord. Why am I saying this? Because in terminal patients, cancer patients with intractable pain, the only solution to control pain or to abolish pain is by doing cordotomy. Cordotomy means destroying the anterolateral column to prevent the pain sensation from coming from the pelvic area, actually. In tabes dorsalis, there's affection of the dorsal columns of the spinal cord, so there's no awareness of micturition, no awareness of full or empty bladder. This leads to automatic bladder. Automatic bladder means once it fills, it empties itself. Once it fills, it empties itself. Automatic. There is no control. Obstruction of the urine outflow in the urethra beyond the urinary bladder means from the membranous urethra downwards, either the membranous urethra only in females all the membranous and penile urethra in males. Any obstruction in this area will be reflected on the urinary bladder. Urine will accumulate in the bladder, will distend the bladder. Now, this is a living tissue. The lining of the bladder will get hypertrophied to overcome the pressure by the accumulating urine. Once it gets hypertrophied, trabeculations will increase in the mucosa. Trabeculations means pockets between the folds of the mucosa. These pockets will hold urine in it. Once urine is stagnant in an area, it gets infected, and this produces cystitis. Now, if it's neglected, it will ascend via the ureters to the kidneys with what's so-called the ascending pyelonephritis. So once started cystitis, don't neglect it, or else it will complicate into ascending pyelonephritis. This is totally a different issue. So this is what I have to say about the urinary bladder and pelvic ureters. I hope you got the maximum benefit from this lecture, and thank you very much for watching.